that. Thank you.
Well, thank you, James. Thanks for the kind introduction, and thanks for organizing this day. It's been a lot of fun so far. I've seen a lot of friends I didn't expect to see. I realized how deeply my roots in the Bay Area go, and I look forward to speaking about this trial with you. Very timely, very multidisciplinary, and I think we'll just get into it. But this is a trial that's been long in the making, and you know, a lot of different people and parts have been involved, and so it's with great pleasure that I get to share this with you. Here are my disclosures. So before delving into the PE-TRACT trial, I just wanted to make sure we were all on the same page, just thinking about the disease in general, and then segmenting it out and thinking about the pathophysiology. So, you know, I have a list of trivia here about pulmonary embolism. It's easy to say PE is a big deal, but some of these facts lend themselves to verifying that. You know, I think the estimate currently is that there are 900,000 VTE events every year in the United States. And it's hard to ascertain an exact number for number of deaths caused by PE, but somewhere in the range of 80 to 180,000, 60, 150. That's the point estimate that we're circling around. Should be noted, it is the third most common cause of cardiovascular death following stroke and MI, and 10% are fatal within the first hour. You know, not all of them present in shock, but 5 to 10% do, and that's a number we have to remember. And a large minority, actually, if you put an echo on each one of these patients, up to 40% would have right ventricular dysfunction of some measure. Importantly, the thrombus that you see at the beginning doesn't always resolve.
Yeah.
No worries. People are there. 1/3 of patients will have residual thrombus if you looked at a lung scan or if you looked at a CT in the months following their PE. And as we'll see in later slides, 1/3 to 1/2 will have diminished exercise capacity. Now, they might have had that before the PE, it's hard to know, but this observation does hold. So all of this points to, hey, we got to do something about PE. So interventionalists, whether you're a cardiologist or radiologist, gets excited by these statistics, but there are some things to temper that enthusiasm, I would say. The first is that most patients have low-risk PE. So 60% of patients will have low-risk PE, and really anticoagulants are the mainstay, and it's hard to say that they need more than that. Submassive PE, which will really be the subject of today's talk, carries a lot of controversy, a wide range of attitudes. The aggressiveness with which we should treat these patients is still not established. Okay, so I've already thrown out some of these terms: low risk, intermediate risk, high risk. What am I referring to? So when we see this patient on the CT scanner, we have a tendency to have a knee-jerk reaction that this is a massive PE. Well, it probably is with that amount of clot burden, but that's not necessarily the case. The definitions are based entirely on hemodynamics and not clot burden or clot location. So in 2011, the AHA took a first stab at this and created the categories of massive, submassive, and low risk. Massive PE being any PE associated with hypotension or the need for vasopressor support. Submassive PE, these patients were normotensive, meaning they had a blood pressure greater than 90 millimeters of mercury. However, they had some evidence of RV dysfunction on some measure, and that could be via biomarkers or via some imaging parameter. And low risk PE is the absence of hypotension and the absence of RV dysfunction. So these were the three definitions, and it was sort of derived from their mortality, which I'll get to in a couple slides. A few years later, the European Society of Cardiology decided to modify this and call it a different name. This is more the convention now than those massive, submassive, and low-risk PE designations of the AHA. And the European Society of Cardiology, really their contribution was breaking down the submassive category and calling it intermediate risk into intermediate high and intermediate low risk. So intermediate high risk refers to the fact that there's a positive pulmonary embolism severity index score, which we'll get to on the next slide. But beyond that, you had to have both imaging evidence and biomarker evidence of right ventricular dysfunction restraint. Intermediate low, either one of those had to be present, or not, even not, if neither one was present, but you had a positive S-PESI, you were in that intermediate low category. And this designation is a little bit artificial. It's not entirely based on outcomes. It's kind of, it was the entry criteria actually for the PYTHO trial. And that's how they sort of segmented it out. But we haven't really gotten to the point where this is absolutely the way we should segment out the population. So stratification requires some work and probably will get better as randomized trials get completed. And low risk is the equivalent to the AHA low risk. Brief word about the PESI score. You can see that there are all these parameters on the left, in the leftmost column, but I'll focus you on the simplified PESI score, which distills it down to those 5 or 6 variables. And if any one of those is present, then you have a positive S-PESI. And that was actually validated in the study in the late 2010s. So that's what we mean by a positive S-PESI, is any one of those criteria being present in your pulmonary embolism patient. Okay, this is the part where I start to get nervous when I talk to cardiologists, but I'll go forward anyway. So pathophysiology, with PE, the RV is everything. So here we see a D-shaped ventricle. On the CT scan, you see bowing of that intraventricular septum, and that RV to LV ratio is probably well over 1.4 or 1.5. So this is where the RV starts to get in trouble, and then acute PE actually becomes an immediate concerning issue. Again, I am now currently very nervous, but I'm going to go forward. And I'm nervous for 2 reasons. First, I'm talking to cardiologists. Second, every time I see this, I'm trying to figure out which side I go down first. But I'm going to do this. Okay. Do I get a yes? Does that show up? Great. Okay. Pulmonary embolism increases pulmonary vascular resistance, RV pressure overload. Okay. So far, so good. So that increases RV wall tension. And from what I've read, this increases RV myocardial oxygen demand, and also according to Laplace's law, it creates a difficult gradient between the coronary perfusion and the actual intramuscular perfusion. So this will in turn lead to RV ischemia and infarction. And this, in combination with the dilation of the RV that's happening anyway because the RV pressure overload, leads to hypokinesis. The muscle fibers are also not contracting at their most efficient orientation. So all of this is happening. And if enough of this happens, you're not going to get enough blood flow to the left ventricle, which decreases LV preload. The other part of this, at least is theorized, is that intraventricular septal bowing actually collapses the LV cavity itself. So your LV preload goes down. When your LV preload goes down, you can't generate as much of a blood pressure. Coronary perfusion goes down. Once coronary perfusion goes down, you're going back into the vicious cycle of not feeding that ventricle, the right ventricle, enough oxygen, and then you reach this spiral of what we call the RV spiral of death. Now, my only contribution to this is that if you were to draw a dotted line across that, I would say this is the separation between intermediate risk and high risk PE, or submassive and massive PE. Hopefully I did not mess that up. Okay, but the majority of this talk is going to be clinical and talking about submassive PE. And why is that? Well, so I alluded to this earlier, but when we stratify PE, we talk about massive, submassive, and low risk. Massive PE with a 25 to 65% mortality, submassive PE with a less than 2% mortality and basically about a 5% rate of clinical deterioration, and low risk with a less than 1% mortality. So the stratification is fair if you consider early mortality from these different strata. It also makes our purposes very different when we're approaching a patient with one of these 3 types of PE. A massive PE patient with that mortality, we probably need to do something more than just anticoagulate and wait. I don't think there are a lot of people that would argue with that. But submassive PE, this is where things get controversial. We used to think that the mortality rate was actually pretty high in the first 7 days, and that just hasn't been borne out in randomized trials. So what is our purpose if we're going to actively remove clot from these patients? Are we trying to prevent mortality, prevent hemodynamic deterioration? Or are we trying to prevent something longer term, which is really going to be a focus of the talk later? In low risk PE, really what we're trying to do is just immediately get patients on anticoagulants so that they don't progress to the submassive or massive categories. So let's talk about this. There has been an evolution in the way we thought about submassive PE. It all started in the late 90s with these registries, these international registries. There was a MAPIT registry and then this ICOPA registry. This one was run by Sam Goldhaber. And basically what this observation was that if right ventricular hypokinesis was present, these folks had a higher mortality in the next 3 months. So that spurred a bunch of randomized clinical trials that were run out of Europe that culminated in the PYTHO trial. So this was a comparison of systemic thrombolysis versus placebo to see in short-term intermediate high-risk PE patients which group did better. And what we found was that this was actually a positive trial, that the combination of death or hemodynamic deterioration happened less commonly in the tenecteplase group than it did in the placebo group. Now, this was driven entirely by hemodynamic deterioration, so mortality was not different in the two groups, but deterioration seemed to happen more commonly in the placebo group at a clip of about 5%. So clinical deterioration is a real thing. And I would say that many people would say that's kind of worth it, but it was at the risk of major bleeding, major and intracranial bleeding. So a 10% major bleeding rate and about a 2% intracranial hemorrhage rate when systemic thrombolytics were administered. So as a result of this trial, given the small net positive that might be coming out of this, in most patients, systemic thrombolysis has a questionable risk-benefit profile in terms of submassive PE itself. But are there other safer therapies that can confer the same benefit? And that's where catheter-directed thrombolysis started gaining traction, at least in theory. So catheter-directed therapy, what is it? Well, so this is a often used and poorly validated model. It's a plastic model with a random balloon that's obstructing inside the plastic model. But what they showed in this was that if you circulated particles, colored particles, they would bounce off this and go elsewhere, which is what the theory is with clot that's in the pulmonary artery if you administer it systemically. You have to administer enough of it to overcome this effect, and plenty of it will go systemically, and you will have bleeding from that drug. So the idea behind catheter-directed thrombolysis is that you embed a catheter into where this balloon is positioned, and you give local TPA or whatever fibrinolytic drug you want to give, and it will have the same effect of dissolving the thrombus, but at the same time not go everywhere. You don't have to use as large of a dose, so your bleeding complications are limited. This is the poster child for catheter-directed thrombolysis. This is a patient who came in with a submassive PE and was in that intermediate high-risk category for sure, had a pretty high main PA systolic pressure. You can see that large thrombus in the right main pulmonary artery. On the left side, you can see those pockets of thrombus in the left lower lobe pulmonary artery extending out into the branches as well. And 2 infusion catheters are placed, and you infuse it at a total of 1 milligram an hour for about 20 to 24 hours, bring the patient back, he's feeling great, and you have these pulmonary angiograms that look pristine. Right. So if this was the case every time, maybe this would be the standard of care. But one thing we don't know is how this patient would have done if we just infused saline, just being the devil's advocate there. Maybe a preview for what I'm going to talk about later. But so this is an exciting development. And just to talk about catheter therapies with a fibrinolytic drug, these are our options. The one you saw in that case is actually this catheter on the left, the Unifuse device, which is basically just an end hole occluder, and you have all these side holes which are administering the TPA inside the clot itself. That's the theory. Now, whether it's actually in the middle of the clot or the side of the clot, that's up for debate. This catheter in the middle is the EKOS catheter. I'm sure many of you are familiar with this. This is posited as something that is penetrating the clot more with an ultrasonic augmentation, and that's breaking down these blood clots more faster and more effectively than they would be with just a random infusion catheter. There has been no head-to-head comparison other than one trial, which is really showed one benefit of one over the other, but that is the theory for the EKOS catheter. And the newest kid on the block is this catheter from Thrombolex called the Bashir endovascular catheter. It goes into the body looking like a straight catheter, then you pull this tab at the back and it opens up like a shallot, and each one of these limbs infuses TPA. So you get sort of what they call fissuring of the clot, and then administration of this of the fibrinolytic directly into the clot circumferentially. So these are what we have on market right now. There have been quite a few prospective catheter-directed thrombolysis studies. That's what the CDL stands for. So just for convention, I'll be calling CDT catheter-directed therapy, catheter-directed CDL catheter-directed thrombolysis, and MT mechanical thrombectomy, something I'll allude to later. But you can see that about 680 patients have been treated in these prospective CDL studies. Pretty good, right? Well, yes and no. Only 2 of these are actually randomized. The Ultima trial and the Canary trial. Ultima was about 59 patients, and the Canary trial was 94 patients. So we're looking at about 150 patients or so total that have been randomized. And there's still some issues with, the conclusions one draws from that. But if you're going to remember the status of the data currently, as of today, this is the only slide you need to look at. This is the only positive data we actually have for catheter-directed thrombolysis or mechanical or any sort of catheter therapy in the literature currently. Yes, we'll stay with that idea. And what it shows is that at 24 hours, if you randomize patients to either receive catheter-directed thrombolysis or not, the group with catheter-directed thrombolysis will have a reduction in their RV to LV ratio by echo at 24 hours, whereas the heparin group will not. That's the only data we have that shows catheter-directed lysis actually works. Now, I'm not saying it doesn't work, but this is the only comparative data we have. So I just want to put that out there. Now, there are single-arm studies that have come since that have sort of augmented that idea and created associations, but that's all they are, because Seattle 2, for example, was a single-arm study, and at the 48-hour CT, we saw this reduction in the RV to LV ratio, but there was no control group. So we don't know what the confounder of heparin would have done on these CT scans. Now, the other part of this is that if you think about a patient coming in for a trial like this, they get their scan on a Saturday, then maybe the research team is really on it and gets to this patient on Sunday. Well, they're not going to do the procedure until Monday. So then once they do the procedure, then 48 hours after the procedure, they get the CT scan. So from the baseline CT scan to the final CT scan hasn't been 48 hours. It's been longer than that. And that's even longer for heparin to do its potential good on the RV to LV ratio. So anyone that says that CDT actually reduces the RV to LV ratio on CT by 48 hours is not really telling you the full story. I think the Optimize trial is important to mention. It's a dose duration randomized trial, not randomized controlled trial. They had 4 groups with ascending amount of fibrinolytic drug administered. And 2 conclusions from this. The first is that in all groups, the RV-LV ratio was reduced the same at 48 hours using the same mechanism of the 48-hour CT scan. Okay, so it didn't matter if you administered 4 milligrams of TPA or 24 milligrams of TPA. All groups had the same RV to LV ratio reduction, which begs the question: what about the group that didn't get any? How would that group have done? Would it have the exact same? But something was different about these groups, and that was the amount of clot that was removed. And unsurprisingly, and this bottom graphic is what that shows, the more TPA you gave, the more thrombus was removed. So it was more efficacious from that standpoint, but it didn't really make a difference in terms of reduction of RV to LV ratio. So really a lot of problems with this trial also. I should point out that Ultima was the only randomized trial until the Canary trial was published in the middle of the pandemic. It was actually cut short because of the pandemic. It basically had similar findings to Ultima, so I won't belabor that. Now let's talk about safety for catheter-directed thrombolysis. Well, it's not harmless. So major bleeding does seem to happen about 4 to 5% of the time, and intracranial hemorrhage does happen, and it maybe happens 0.2 to 0.4% of the time, but it does happen. And so there is a bleeding risk associated with CDT. Now, this new catheter, the Bashir catheter, which I talked about earlier, had a really, really low major bleeding rate of less than 1%. So maybe this is a signal that we're getting better at our at our technique, at our regimen. But it should also be pointed out that Rescue PE only had 109 patients. So really, do we truly have the full number that we can assess the bleeding risk of this technology? We don't. What was also interesting that I'd like to point out about this is that there was about 14 milligrams of TPA given in this study, and it did show the largest reduction in clot burden than any of the core lab adjudicated prospective studies so far. So that is an interesting signal that also needs to be validated, that maybe we are getting better with our technology and our ability to both minimize the amount of TPA through using a mechanism that maximizes the absorption of the fibrinolytic into the clot. But all this talk about bleeding means that there's room for innovation. Can we actually remove clot without giving a fibrinolytic drug? And companies are very interested in this. As you can see, the number of innovative devices that have come on market for this. And some of them have been trialed prospectively, but they're also all single-arm studies. And so one is with the Indigo aspiration system, that was the Extract PE trial, and then the FLAIR trial, which was with the FlowTriever device. And if you were to compare these trials, they all show the same thing, which is an RV-LV ratio reduction. And you know, the safety of that, you can see that the Seattle 2 study, which was that the second study I showed, had a pretty high major bleeding rate. It was a conservative definition of major bleeding, but it was at 10%. And you can see the other studies seem to have a lower bleeding rate. So maybe mechanical thrombectomy has a lower bleeding rate, but there are other problems with mechanical thrombectomy that we need to recognize before we say that that is the solution. This is the AlphaVac device on the left. It actually just got FDA cleared. So it's the third mechanical thrombectomy device beyond the FlowTriever and the Indigo aspiration system to receive FDA clearance. And this is the JEDI device, which I believe Abbott is trying to begin a clinical trial for. So I think I've said this several times, so sorry for hammering this home, but besides Ultima and Canary, CDT trials have not included a control group. So if you look down this list, none of these has included a control group. And what should it be potentially comparing itself to? Prompt anticoagulation, close monitoring, and advanced supportive care. So all of these outcomes in the middle, I'll get rid of that for a second, RV-LV ratio, which is the surrogate outcome that we're all using for efficacy, and then all these other clinical outcomes, none of them has really been compared in these CDT trials to prompt anticoagulants. And beyond that, beyond the clinical ones, which you see listed here, there are many, many data gaps here. So what is the best method of clot removal? Is lytic better or worse than non-lytic? Can you remove more clot? Does removing more clot even matter? You know, from a clinical standpoint, how much clot are we supposed to remove? Are these enhanced thrombolytic catheters worth the cost? Are they really adding enough clinically to go with that? And of course, there are great basic science and translational questions, and you know that would potentially translate to clinical outcomes. So I think what we're seeing right now, and hopefully this is going to be changing with the RCTs that are coming up, is that there's a tremendous innovation, but it's all based on a lack of fundamental data. In fact, one industry listing or end of year report said that right now there are about 20,000 procedures per year for catheter-directed therapy, but the total market cap is 200,000. Now you compare that to the 900,000 VTE events, and you're just like, how is this even possible? How are we even using that number? It just doesn't make sense. And really, what the guidelines and what a lot of us are calling for is hey, let's back this up a little bit. Let's try to understand this fundamentally to see if, whether we should remove clot in the first place before going to a number of like 200,000. So you look at all of these guideline statements: 2019 AHA statement, the European Society of Cardiology, Society of Interventional Radiology, American College of Chest Physicians, ASH guidelines. They're all saying we need better data in this space. And to summarize, there are really two reasons we haven't been able to establish catheter-directed therapy's role in the treatment of submassive PE. The first is the lack of randomization issue, which we're really beating up that particular point. In systemic lytic trials, not just Pytho, over 16 or 1,700 patients have actually been randomized for us to understand exactly what's happening with systemic thrombolysis and intermediate risk PE. And we have a total of 150 with catheter-directed therapy. The second thing is this RV to LV ratio has been overstated, and it's because it's the FDA's way of saying this is your first step towards showing efficacy. But we've gone from that to marketing these devices as ready for use. So the second problem is we need to get beyond this RV to LV ratio and actually look at clinical outcomes, short-term and long-term clinical outcomes, and how CDT affects those. Well, fortunately, we are now in a new era. When talking about short-term clinical outcomes, we're talking about mortality, clinical deterioration, bleeding. The industry-sponsored studies are trying to address that. So HI-PEITHO is sponsored by Boston Scientific, and it is a catheter-directed thrombolysis trial using the EKOS catheter. And it is enriching the intermediate risk population to be really quite sick to see which patients of these would deteriorate more commonly if not given this EKOS catheter. And then the PEERLESS 2 is actually sponsored by Inari Medical, and it's the mechanical thrombectomy. It's hard to say equivalent, but semi-equivalent of the HI-PEITHO trial on the mechanical thrombectomy side. The STORM PE trial is actually more similar to the ULTIMA trial, but is being run by Penumbra, and it's using their Indigo aspiration system. Now, in contradistinction to these short-term industry-sponsored trials is this longer-term PE track trial. And that's what I'll be spending the next 10, 15 minutes on. And I want to give you some background on PE tract and tell you where it's been and where it's going. So let's back up a bit and ask the question, are long-term outcomes in PE important? We've always thought about this as an acute disease. Is there a reason to think beyond acute immediate problems and look at into the years following it? Well, theoretically, this is what's happening. You have residual thrombus after a submassive PE. This increases pulmonary vascular resistance, increases dead space, RV dysfunction. Now, is that a permanent finding? Well, some epidemiologic observations suggest that this is leading to some issues. So this increase in mortality in this population, increase in CTEPH in this population, functional limitation is common. I'll get into some slides with that. Shortened 6-minute walk distance, reduced QOL. These are all observations in post-PE patients, kind of circling around this idea of a post-PE syndrome, which has admittedly not been well described. So this study by Susan Kahn in 2017 really highlighted this issue. And what she did is she took 100 patients in 6 or 7 centers in Canada and just observed them. And at, I believe, 3 months and 1 year, did a CPET on them, cardiopulmonary exercise test. And what she found at the 1-year time point was that 46% had a reduced peak oxygen uptake. And these were people that didn't have a whole lot of baseline comorbidities. And most of them were actually low-risk patients. So this is very surprising to the PE community that this many patients had functional difficulty as measured by CPET 1 year after their PE. And that number, 46%, has actually been corroborated in several other studies as well. And then 30 to 50% have some functional capacity reduction. We did the systematic review, which showed that NYHA class greater than 2 was present in nearly a third of patients. And any studies that actually did a 6-minute walk distance on these patients found that their 6-minute walk distance was 415 meters. Well, that's not very good. That's the 4th percentile of what they should be. So the question that stems from all of this observational data is, will arresting this biology improve these long-term outcomes and eliminate or reduce the incidence of some of these other deleterious things? And that's the basic concept for PE tract. So PE tract, it's funded by the NHLBI, and I'll tell you the story of how it ultimately came into being. Actually, I won't. We can get into that later. We can talk about how this all came into being. But it was funded by the NHLBI in 2022. These are patients who have intermediate risk PE by CTA and have proximal thrombus. Up to 500 patients will be enrolled, but that's not necessarily going to be the final number, and I'll get into that in the next slide. These patients are being randomized to catheter-directed therapy or anticoagulants alone. And it's important to specifically say catheter-directed therapy plus anticoagulants, because when consenting patients, they often ask, so I don't have to take blood thinners? No, you absolutely have to take blood thinners. And the catheter-directed therapy part of it, remember that's the umbrella term, that includes either catheter-directed thrombolysis or mechanical thrombectomy. So we're including any FDA-cleared device except the AlphaVac, which was recently cleared. We can talk about that in a discussion in the trial in the catheter-directed therapy arm. Now, our primary endpoint is not the short-term outcomes that you heard about for the other industry-sponsored trials. It's the peak oxygen uptake at 3 months and the NYHA class at 12 months. Now, in the next slide, I'll get into how those two are being analyzed as dual primary outcomes. But in addition to those as the primary outcomes, we're going to collect a bunch of things: fatal and non-fatal clinical deterioration, quality of life, 6-minute walk distance at 12 months, thrombus burden at 48 hours in both groups. So we'll be able to see what anticoagulants do to that RV to LV ratio. Of course, bleeding, recurrent VTE, and we also have a robust health economic analysis as part of this trial. So the whole evolution of our primary endpoint changed when we got a U34 grant in 2018 and used the Berry Consultant Group. And they suggested this Goldilocks gatekeeping approach for a dual primary outcome. And the whole philosophy behind this is that PE has a physiologic consequence, but it also has a consequence for the patients. Is there a way we can take a combined endpoint? Well, it's not a combined endpoint, it's two primary endpoints, and sort of report what happens in these two groups through these two principles. And what we decided upon was, piggybacking on Susan Kahn's study on the CPET and the peak oxygen uptake, to use that as our physiologic study, and then the NYHA class as not really, I know it's not traditionally a patient-reported outcome, but as a reported outcome on the patient's functional capacity. And so what we also realized is that NYHA class on its own would be questioned because of the potential for bias, since this is not a sham-controlled study. So we wanted to link that patient-reported outcome to a physiologic one. So if the CDT group has a higher peak oxygen uptake, then only will we analyze the NYHA class. So that's what we call the gatekeeping approach. The Goldilocks strategy is the Bayesian component of this. So basically, the Goldilocks strategy is getting the information we need with as few patients as needed. So it's just the right number of patients for the answer for the question you're asking. So just not to go through this in gross detail, but let's say you have a situation where the peak oxygen uptake looks like it's going to be positive, even if you projected it out to the full 500 patients. But it looked like the NYHA class was not going to be positive, even if you went to the full 500 patients. You would stop at that point and it would be called a successful trial. Now, if let's say you get to 250 patients and there's no chance at 500 patients you're going to actually have a positive trial on the peak oxygen uptake, you're going to stop the trial right there. You're not going to keep going for the NYHA class based on what I just talked about for the gatekeeping strategy. So there are different scenarios here for the stopping guidelines, both for futility and for efficacy, starting at 250 patients. So that's the science. Now we're going to get a little soft, which is fine. It's a good time in the talk to get a little soft. The PE tract implementation timeline so far. So in September 2022, the team was assembled. We got our first protocol version and ICF approved in 2023. Our first site was activated in May 2023. The DSMB finally met for the first time in June 2023. No patients can be enrolled until the DSMB assembles. Just something you learn when you're doing these things. And then the first patient was actually enrolled in July 2023. And then September 2023 was when the second site was actually activated and enrolled a patient. And by May 2024, we have currently 110 patients enrolled with 40 sites activated. So zooming out a little bit, one slide on the importance of PE tract, and then a couple slides on imagining what the post-PE tract world will look like. Why is PE tract so important? It is the only non-industry sponsored clinical trial. I'm not disparaging the industry sponsored clinical trial, although some of them do have design flaws, I think. But it's the optics of the situation. If all of the data was coming from industry and there wasn't a single independent source, that would be a problem. I am really serious when I say that our group is very, very motivated to find the correct answer for PE patients. We're not rooting for catheters, even though we're interventional radiologists and interventional cardiologists on the steering committee. We really have seen enough data in this space to really want to know what is really happening with these patients when they get this therapy, and should we be doing it routinely? It has true randomization against anticoagulants alone, a large sample size, and it is a clinical assessment of CDT. It's not using a surrogate outcome to make conclusions. All right, letting our imagination go a little bit, a post-PE tract world, finally being able to advise an anxious intermediate risk PE patient whether they should or should not get this therapy. It's a point of frustration for all of us that have to approach these patients in the hospital currently. Individualizing care based on subgroup analyses. So this whole thing about, well, does CDT actually do anything? You know, if you remove the clot, do you actually reduce the RV-LV ratio compared to heparin alone? Well, we'll be able to answer that, but more importantly, we'll be able to answer whether that matters, because we'll be able to correlate that with actual clinical outcomes over the course of the next year. Knowing exactly what's going on with patients who have persistent dyspnea and exercise intolerance. So it's not just about the peak oxygen uptake. The CPET gives us other parameters that will give us some pretty interesting specific physiologic data. And we're actually applying for ancillary funding to see if some of those parameters actually, if we can analyze those even further. The health economic analysis is being done by the MAHI group, which has done a bunch of cardiovascular clinical trials. And I think that will be a very interesting paper in and of itself. We are collecting blood biomarkers both at baseline and at 3 months, so correlations will definitely be made there. While we are not powered to figure out which CD.
Yeah. That's fine.
Okay, I'm done. I'm sorry. Okay, God has spoken. Mechanical thrombectomy versus CDL.
No, that's okay. I'll talk to the procedural people. Yeah. I just, okay, thank you. Yeah, okay, bye.
Okay. Oh, that's awesome. You know, you've been talking too long, Lynn. A spec sheet for novel devices in pharmaceuticals. So we really do hope this trial spurs further innovation, a more precise definition of the post-PE syndrome, and then finally guidelines, level 1 recommendations. This is our community, greater than 200 physicians. All of these societies are supporting it. It's a real movement. We really hope to get this done, and what we think we will. We're at 111 patients now, 39 sites activated. We hope to activate UCSF within the next few months, and looking to get 13 to 15 enrollments per month. So small RCT, single arm studies have given us signals, but we have not answered the most fundamental questions about CDT when it comes to submassive PE. Era of randomized trials is here. We do need to distinguish PE tract from the group for the reasons we discussed. But I'd like to actually conclude with some reflections about what I've learned so far. Before PE tract, I was a site PI. I'd helped with some industry-sponsored studies, but this has been an experience unlike any of those. And this is what I've learned. It's definitely a team sport, and relationships are as important, if not more important than the science, in order to get a study like this done. My mentor in this whole thing, Suresh Vedantam, had done it 1.5 times before helping me with this, and his knowledge and experience of running a clinical trial from soup to nuts is unparalleled. We don't even know what direction the results from this trial will take the PE community, and that's okay. That's all right. I've had to learn a lot of different roles in this role as the national PI, you know, spokesperson, writer, speaker, scientist, methodologist. Some of these I'm better at than others, and you know, you have to fill in your weaknesses. But you know, at the end of it, you absolutely do need to be a physician, and so that's a really important lesson that I've learned here. You don't want to mess things up. There's a lot of stuff going on. You have to herd cats, which is what we as physicians are. We have to enroll and retain participants. It's a lot to do, but you have a great team to do it, and it is scary. And you realize how much bigger this is than you. There's so much more writing on this, but at the end of the day, it is a lot of fun. So I hope you enjoyed that. I am absolutely open to any questions we might have, and I think we're in good time for that. So thanks a lot.